without further ado, I want to introduce today's speaker, Dr. Curtis Lowery. And we had just returned, a lot of us, yesterday from the American Telemedicine Association, where he received the Institutional Award for the Advancement of Telemedicine. And so this is a huge award and a huge honor for us at UAMS and Dr. Lowery. Dr. Lowery is the professor and chair of the Department of Obstetrics and Gynecology. He is also the medical director of Angels in the Center for Distance Health, and he is also the PI on the CTSA award. And here's Dr. Lowery.
Thanks. Sarah, I really appreciate it. Thanks a lot. Thanks, everybody. So it was a great honor, but it's an honor for everybody in the group, right? Because that's the way we work as a team. And like I said, it takes a village to raise a child. So it takes a village to change healthcare, and that's what we're doing with the concept of connectivity, right? Systems that are disconnected are independent and have to function on their own. And by being connected, you can accomplish a lot more than you could if you're a single cell creature. Think about evolution. We started out as single cell entities that then became more connected, and through the connections could specialize and do more intricate and more complicated things. And I think that's the way you might want to look at healthcare. It's a sort of a disconnected system without strong relationships and independent people working independently, and that's okay when you don't have antibiotics and you don't have respiratory therapists or ultrasounds and x-rays, but once you begin to have more complicated systems, I can tell you I've never ran an x-ray machine in my life. I never will ever run an x-ray machine in my life. But I work with people that can do that, and I know when it's appropriate to order an x-ray and when not appropriate. And so by designing systems, you can do that kind of stuff. And telemedicine, distance health concept, allows us to have systems that can reach out and do things across great distances from even other parts of the world. So we'll talk about how we got started with this and maybe where I think it might go in the future. And so this is the Arkansas telemedicine structure, how a rural state went from healthcare isolation to a connected healthcare system. And we're going to talk about lessons that we learned in that transformation from to a connected system that improved patients' access to healthcare. And that's the ultimate goal, is that I have been always in universities my whole lifetime because I wanted to be somewhat disconnected from what I did to the patient and how it profited me in some way. And so I've always thought like that a little bit. And I think now when we begin to really do healthcare transformation, we can have huge impacts across large systems now as a result of this. And so we got involved in this because in Arkansas, 73 of 75 counties are designated as medically underserved, with healthcare access being one of the most overwhelming reasons for Arkansas's poor health standing. And you can see here we have entire county designated as underserved in blue, and red is partially county designation as being underserved. And so we have not nearly enough physicians to go around. Now add 250,000 new patients with insurance that doesn't have it, and you see how this rapidly becomes much more of a problem down the road. Right now, if you don't have insurance, you end up often not getting care, and you end up going to the emergency room and getting care when you're so ill that you have to be admitted to the hospital with severe pneumonia or problems with your blood sugars. So, and that happens. Barriers to care cause this, and some of them are language and cultural. There are areas of the country and world where there's just a general distrust of health care. And if you live in an isolated area, it's difficult to have transportation against great distances. We had a discussion today with the public health department that said that even if it was talking about treatment of cervical dysplasia, even if the treatment is free, they don't often have money to go to a center to be treated. So we talked about how can we move the treatment into the rural area to that individual so they could get their cervical cancer treated. And of course, money is always a big problem with healthcare in America. Since they're around 30 to 40% of the population of Arkansas doesn't have health care. They do not have health care. So that's how bad it is. And largely because this is a poor state without a huge economic base. And in order to get Medicaid funding for your population, you have to be able to provide 25 cents on the dollar. So for every 25 cents you can come up with in Arkansas, you can get 75 cents worth of health care, which is, I don't know anything that you can be guaranteed immediately, 3 times your money investment. But the state can't afford coming up with the 25 cents, so many people don't have access to health care. And because if you don't have a job with insurance, often you can't get access to it. And there's limited access to medical subspecialty support in the rural areas. So you may go to a hospital, but there may not be, for instance, a nephrologist or a nephrologist, a neurologist in that hospital, so that they can't treat your special neurological problem. And due to the delayed care and lack of insurance, due to the problems in the system, there's often a delay in accessing care, which results in more serious harm to the person, more expensive to treat the person, and a general increase in cost of health care, because in America still, if you show up in an emergency room, somebody's going to treat you. I've been to third world countries, India more recently, and you go to the emergency room, you'll see people on stretchers outside the emergency room dying because they couldn't get in the hospital. They didn't have money and couldn't get in the hospital, or there was no treatment for them. So you don't see that in America. And because of the nature of the healthcare system, there are these silos in which subspecialists don't communicate with one another. Hospitals don't communicate effectively with others, and insurance companies don't communicate. So there's isolation and walling off of this communication within the healthcare system. And so when we began the telemedicine efforts, the economic and political climate was far from perfect. Although the steps to move forward from isolation to saturation were staged over 7 years. So we started out and began the very first hospital was in North Arkansas at Willow Creek Women's Hospital. And in that hospital we were able to put in a T1 line, and it worked well there, and then it began to expand to other OB hospitals and expand to the large, robust nature of the network that we have now. We have the Angels program, and then the Telenursery and Arkansas Saves are the three largest programs that we have working. And actually, the Telenursery is sort of part of Angels, So it'd be OB, I'd say OB, nursery, and neurology, the stroke program. And you see around, these are the sites around the state that we have. They're Angel sites. Does this include the ERs for stroke too? This is just OB and nursery. So all these are sites that we're doing either Telenursery or Tele-OB into. And you can see that we're all over the state. Soon there'll be one of these little red angels everywhere after we get through the BTOP. So since 2003, Angels has decreased mortality by 0.5% in neonatal mortality, finalized 97 obstetrical and 51 neonatal and 11 pediatric evidence-based guidelines, which will provide the framework for us to do healthcare reform in the next few years in OB and neonatology. And we've delivered 9,100 high-risk obstetrical telemedicine consults to women in rural Arkansas. And we facilitated over 4,181 maternal transports to the most appropriate hospital, not necessarily to UAMS. And since 2010, Angels has performed 3,306 telemedicine consults, facilitated 619 high-risk maternal transports to the closest hospital, administered evidence-based medication recommendations to 50% of neonatal transports that were not otherwise administered best practice, accepted and made 209,149 obstetrical support calls through the 24/7 RN staff Angels call center. So we're taking a lot of phone calls, and that's been one of the most successful parts of our program is the 24-hour call center. And we've held 53 obstetrical and neonatal provider teleconferences reviewing evidence-based guidelines with a total of 1,822 attendees. So you can see the telenursery site all over the state. And these are sites that the neonatologists here are making consults into the nursery using interactive video. So it's like a neonatologist goes and visits that nursery and examines that baby and talks to the nurses and providers in that nursery. And in these telenursery services, we make census rounds Monday and Wednesday and Friday, educate and case conferences and consults on neonatology, genetics, and cardiology. The Arkansas Slaves program, stroke, I forget the A. Stroke Assistance through virtual emergency services. Okay, so Arkansas Slaves. And then you see the flags are places that we can actually go in and do telestroke consults 24/7. So we have neurologists on call 24/7 that have equipment in their homes as well as at work. And we've done since 4/25/11, just as of this date, we've done 403 consults and actually treated 117 patients with TPA for a total of 29% of all consults. So 30% of the patients that got consulted got treated. And before SAGE, less than 1% of patients eligible for TPA ever received it. So we went from 1% to 29%. And each of the 27 hospitals that participated in Arkansas SAGE used evidence-based guidelines in the treatment of acute ischemic stroke standardized protocols for the treatment as of the American Heart Association and Stroke. So a big part of what we do is we implement protocols and checklists, and we try to get people to follow the protocols and checklists. And it's just that simple. It's sort of like the aircraft industry does this every time an airplane takes off. Why don't we do that in healthcare? Makes no sense. It's more efficient and safer and better for the patient ultimately. Better for the nursing and actually physician staff, because now if you're trying to do everything one way, then it's not so damn confusing for everybody. The nurses doesn't have to know 10 different ways of giving a drug. They can just kind of try to memorize one way, and everybody agrees this is a reasonable way to give the drug. Okay, so the current initiatives are ophthalmology, geriatrics, psychiatry, rehab medicine, ER and trauma. And then I told you about the Arkansas SAGE, Human Developmental Center, Division of Behavioral Health Services, cardiology, correctional medical services. We're doing a lot in the, well, not a lot, we're doing a lot of obstetrics and gynecology in the prisons, where we do telecolposcopy in the prisons, which has been a very effective program. Unfortunately, a lot of women prisoners have a lot of problems with cervical cancer, so it's a real common thing. And so in the past, being in prison has been an impediment to getting access to care. But it's not so much anymore with this program. Okay, so the model that we operate from is we put equipment in the community and teach the community how to use the equipment, and teach the community how to follow the protocols, like with the stroke. And so we have a reliable network structure, and we decided early on it was very important for us to maintain the network structure and not to be dependent on other systems. When we started this quite a few years ago, the telecom companies mainly ran the networks, and they really didn't. This was only a very secondary part of their profit center, and so they really weren't that interested in it. And so we, in order to get the service that we demand, healthcare, you can't have it fail. So in the past, our switches at one point went through St. Louis. They had a guy, because I remember when this happened, guy that was at home, and you'd have to call this guy and wake. If the system failed, you'd have to call this guy in the middle of the night time. He'd have to drive to the work, and he'd have to go there to mess with the equipment. And so it was just ridiculous. Sometimes it would take 2 hours to get the thing fixed. Well, if you have somebody in the ER that you're trying to decide about giving TPA, you can't really let that happen. It has to be a reliable system that you can maintain and keep operational. And we had to create partnerships with groups, with the health department, practitioners, hospitals. And we had to seek funding because, before you could learn how to read, if somebody said, "We want you to buy this book for $50, and if you couldn't read, you'd say, "Well, I don't know what the point of buying that book for $50. But once you learn to read, you realize that, oh, that's valuable to me and I want to be able to read, so you pay $50 for the book. So that's the same way it is with the telemedicine equipment. Until people see the utility in it, then they're not willing to pay for it. But as it matures and people see that it really allows them to have access to resources they can't get to otherwise, then they'll be willing to pay for it. And many hospitals have already been willing to pay for it. And down the road, after we get out of these pilot projects that we're doing, if it's valuable to healthcare, then it will happen. If it's not valuable to healthcare, it should become extinct. It should go away. If it's of no value to anybody, then just don't do it. You know, you can unplug the system and shut it down. I've never seen a system in technology. The internet didn't shut off. And it costs money to be on the internet now. So I think this is the same. Connected systems just get more connected usually. And then we develop programs that are efficient. Now, one thing we need to be doing is figuring out what programs are efficient, what programs that work, and how should we fund a lot of these programs. And that's a lot of what we're doing right now. And then education and training for providers and nurses, physicians, and other kinds of providers. And then again, the network structure must not fail. You must be able to troubleshoot it in a very short period of time, because if it fails consistently, frequently, then healthcare system will get frustrated with it and they'll stop, or it can kill somebody. If you're dependent on it and it goes away, doesn't work, then it may result in untoward events to the patient. So particularly think about if you're doing robotic surgery across the distance, which will happen in our lifetime, I'm sure. If that failed, then that would be a very bad thing. So you got to be able to support it. And so engineering expertise is necessary. And so as a sort of a pioneer in this stuff, I know a lot more about engineering and the way systems work than I would have otherwise, but it was necessary for me to learn it in order to figure out what the best way to direct the programs toward. And then you need a testing lab capable of putting in a test environment new equipment rather than just putting it online. You know, there's hardly any industry that would do that. No one would put a new untested piece of equipment in the production line. They'd always test it first to try to get as many bugs ironed out of it as they possibly can, and that's what we do now with our equipment. And so the plan is to expand healthcare access, to more and more people. Expand healthcare broadband as much as we can. I'm a very big believer in broadband rather than internet stuff at this point in time, just because the reliability of the service is more consistent. And again, even though $1,000 a month seems like a lot for a T1 connection, it's reliable, it's always up, and all you got to do is just go and turn it on, and it dials the number for you. So the system we've created is a very robust, redundant system that we can maintain centrally. And network security, also by having a nailed up T1 based system, which is more expensive, but it does allow us to secure the network more efficiently than if we were on the network on the internet proper. And we've established standards for appropriate telemedicine services. So in this network, we keep track of what goes on, what kind of consults, because like the policeman on the highways, is our responsibility to make sure that people are practicing. If you're driving on the highway, you can't drive 150 miles an hour drunk. Well, same way with the network of healthcare, you can't do that in this. We have some responsibility protecting the consumers in the network, and there are regulatory mechanisms such as credentialing that we're dealing with. While we're at the telemedicine meeting in Tampa, CMS had okayed the central credentialing of patients, of doctors, and healthcare providers at a central site. Before, they said each hospital had to credential you separately. So they said if I was going to bill Medicaid, I had to be credentialed in every hospital. And now they said no, they'll accept if you're credentialed at one hospital and the other hospitals accept that credentialing, then you're credentialed at all of them. So that's a major turnabout that they made with just this week, so that's very beneficial. And then you have to create partnerships, have a common goal, designate leader, form an advisory board to meet and steer the project, and make certain all partners and their interests are well represented. So we've always had the attitude in this program that we're going to work with other people, we're going to cooperate with other people, and it's not about UAMS or our system taking over the universe. That what we're trying to design is a free, market-based telemedicine system that's available to anybody that wants to use it. And that's our philosophy, and we'll always keep with that philosophy, because ultimately it's about improving the care of the patients in the community. And we don't care how that happens. All we want is for it to happen. And so this shows the ATOM board, Arkansas Telemedicine Oversight and Management Board, and we have Orion, which is we have fiber and we have T1 connections when you get off the fiber. And then the ATOM Management Board is hospitals, centers on aging, county health clinics, community health centers, human development center, mental health centers, public libraries, ambulance service, and home health care agencies. And we've gotten over the years a diversity of funding sources. Early on when we got started, we had local, state, and federal levels. Federal appropriations from our senators were able to help us get started. And then we got FCC pilot program, which we're now in the process of deploying. And then the governor's office agreed to match. So this required a 30% match from local, and the governor's office agreed to match this money. Again, allowed us to get the FCC money and contracts with prisons and network support, and there'll be other contracts that we'll move forward with. But the prison was a good contract that we got initially, and I'd again like to see us expand this into the prisons more, because there are plenty of consult that we could do with prisoners that would improve their care, and yet would not put the society at risk for violent criminals going to a healthcare facility and escaping, which would be a bad thing. Now, women tend not to do that, but not always true of men. So the good thing about women is they tend not to be as violent as men in terms of prison. So, and the Medicaid program, Angels and Angels Saves, a big part of our funding. And then we've gotten a bunch of grants for health care, and then we recently got the BTOP stimulus money. And then ultimately everything has to be sustained. So you can use pilot money to get started, but you got to come up with a way of sustaining it. Now, it is my opinion that this is not a very big problem, because again, if this is a vital part of what we do in healthcare, then it'll be sustained, and that's what I think will happen. And so you got to consider working with other people besides just the other hospitals. And community colleges are a big part of the money that we got for this broadband, and public libraries and public schools. I think public schools are an area for which we need to tap into a lot more, because in the state of Arkansas, every public school has a T1 connection and equipment in that, and most of them have a school nurse. And so the possibility of doing more to treat our state's children should be a big focus of what we're trying to do, because that's an area for which you can treat kids in school and keep them attending school, and not have them get sick and have to go to their doctor and miss a bunch of school. So it should be a focus of improving care through the children through our schools. And so it's important to find people that are champions to work with the programs. We have Whit Hall in neonatology, and we have KRUS in neurology, and so we have individuals that have sort of realized the utility of these programs and adapted them, and then they sort of champion the use of them. This is an Angel Eye camera, for which we put in the nursery to look at the babies, have the parents be able to, from anywhere in the world, browse by computer, internet, on to look at their baby. It's password protected, so you can look at your baby in the nursery. So it's a really good thing if the mother has to leave and go home to their rural area. Often they're 4 or 5 hours away from the university here, and they have to leave their child behind. That was a very scary thing. And so outreach is very important, but the inreach, how do you get the people in like our university system is a big university program with a lot of different faculty. How do you identify and educate internal partners to adapt this technology? And how do you illustrate cost effectiveness from these programs? And how do we assist partners in seeking pilot funding? And very importantly, how do we incorporate research in what we do? Because the healthcare, the insurance providers go, well, nice idea, but does it work? And so you need to be able to say, yeah, it works. Here's how it works, and it's going to save money and improve outcome. If you can't say that, then I'm concerned too that it's just another cost center, and not profitable. And does it improve outcome? Well, we think it does, but what if it doesn't? What if it hurts? What if it does harm in the whole process? There's always potential of any new thing you do to create harm as well as good. And you have to be very careful that in slaying monsters, you don't become a monster yourself. I think there are a lot of well-intentioned programs that have come out and done things and ate up resources and didn't really accomplish anything. So I think we really need to incorporate everything we do, research to prove the effectiveness of what we're trying to do. And then access to subspecialists. I think primary care providers in rural areas struggle with complex patients. But I think that we need to have more primary care providers, and we need to pay primary care more money, because they should be doing the majority of the care for patients. America's healthcare system is somewhat fractured from the point of view there aren't enough primary care providers, and so people end up going to a cardiologist or a neurologist or some other ologist, and they get their care from the ologists, and they don't get care from primary care, and that just drives up the cost of care. For instance, I don't know anything about childhood colds, and if somebody was coming to me, it would be terrible because that's not my specialty. So, and I spend all my time worrying about pregnant women and fetuses, and so it's better to have more people that have a bigger view of the thing and support them with care delivery, particularly in complicated patients. But we all will benefit by having guidelines for care management. I think that's really something I'm very big on. And this approach of subspecialty support allows some patients to remain in their communities while extracting others to subspecialty care more rapidly. The community would receive the market share of the resources in this situation, and it would meet the psychosocial needs of patients to be near their home. I personally have told pregnant women that they had their fetus was going to die, that it would not survive over interactive video. And while it seems bad, if they're in their home, in their environment for which their family is around, the church and all the support mechanisms, that's better than having us tell them in a large city they've never been in and then have to drive 4 hours to be back with their family. That's not as good. And it allows providers access to current best practice, so we can work with local providers sort of on-the-job training with this information. The more we can involve them in our treatment plans and guidelines, it helps them stay current with their practice. So this whole thing is a new way of training providers in the way that we believe that providers should be trained, and that's by on-the-job training. And a residency program is really pretty much like an apprenticeship, in that you go and you work with knowledgeable individuals that teach you the art of healthcare. My father worked at a foundry, and there were millwrights. Millwrights are these guys that learn how to use lathes that turn metal, and so they always got new guys that came and worked with them, and they taught these new guys to turn the metal. It's a very complicated process by creating a piece of equipment out of a metal lathe. It's very technically difficult, and it took a long time for these guys to learn the technique. And that's the way healthcare is. You go and you work with knowledgeable people, and they teach you the art as well as the science of the practice of healthcare. And this kind of process allows you to be kind of connected to the system and continue to learn for the rest of your life. And then communications and marketing, it's very important. If I'm going to ask people to fund this program, it's very important that I show to them why it's important to fund this program. So media campaigns, press conferences, radio spots, television, submit abstracts, national presentations. Our group was all over the national ATA meeting. We got the award, but then we had, I don't know, probably about 5 or 6 talks, and we had 10 posters at this thing. And so that's very much establishing at a national level that we're players in this game, and that our program is an excellent program. And launch outreach team in rural communities, build relationships, identify champions, discuss program and technical issues. And awards and honors, growing recognition for the program. I think we're very much recognized at a national level now with the CDH and Angels. And we offer training and education on telemedicine, and we enable those interested to visit our facilities, and we're very open about sharing our information, sharing our protocols, and sharing our slides even in this. I think that transparency is the way to be in this stuff. We're scientists and educators, and we need to be doing science and educating people. So, and we're very serious about that. You know, if somebody wants a copy of the slides, we'll give them to them. You know, we don't care. That's a good thing. And then so creating a training center is part of this. We have the learntelehealth.org, and we're, you know, South Central Telehealth Resource Center, and it provides online community users, equipment choices, education, educational administrative network connectivity, and hands-on and online training plus in-person training. And we participated in the National Training Center here at UAMS, and we have people from all over the country: New Orleans, Memphis, Chattanooga, Panama City, Albuquerque, just to name one of many others. Oklahoma, Oregon Health Science has been here. So a lot of you know, national programs in Nepal, India, Nigeria, Philippines, South Africa, Uganda, Zambia, Ecuador, all trained in our program and continue to be actively involved. And then you know, there are always barriers, and I think you just got to realize you can get through them and figure out ways of engineering around them when necessary. But very important in the political environments, be aware of stakeholders' interests. Don't create fights if you don't have to, even though there are times I'd like to destroy some of the issues that we face, but it's, you know, not always, it's never a really good idea to do that. It's better to negotiate rather than fight. Be accountable, accessible, and communicate effectively. We try to do that. And state agency turf battles, you should build alliances and try to work and negotiate. And poor communication is always a problem in each system. Our program is suffering from the large size that it's grown to now, and we're beginning to have more difficulty communicating, and that's a terrible thing. We've got to work on that, and that's going to be one of the things the next year we're going to work on, is how to communicate better. Be flexible, patient, and persevere in your activities. Employ a team approach for MOUs and contracts, and fine-tune negotiating skills are very important. We've become much better negotiators as a result of some of the national things we've done as well as local things. And connected health care should be anywhere, anytime, any need. And that's really where you live should not determine whether you live or die, and we really believe that. We operate across the health care spectrum from actually should be a picture of a pregnant lady and a fetus, actually, because we start even earlier. We don't do infertility yet. I guess we could even do beyond conception, and then all the way through to old age. And then this shows the broadband deployment that we're currently involved in. This is fiber, new fiber that doesn't exist right now. This is old fiber that's part of the Ariane four-year school fiber, and there's some more new fiber that we're putting in. So initially we thought we were going to have to put in 350 miles of fiber, and now we're only putting in like 50. What is it, Tina? 50? 50. But we're leasing the other fiber after that. So it builds our network out a lot more robust than it was before, and creates redundancy. And so we've learned that lessons plus success equal a strategy to telemedicine saturation is formed. And that's what we're trying to do. We're trying to build a system by which that you're no more than 30 miles from any kind of connection in the state. And under construction is this Arkansas's only academic medical center, and its partners are building a network of 474 partners. This is the BTOP money, 135 communities, including a hospital network, all four-year colleges and two-year colleges connected, all state human developmental centers. The state trauma network will be part of this, and community health centers, and mental health clinics, and home health care agencies, and many more. And so this is a UAMS, it's a really connected system where telemedicine lives. And I would argue that as we begin to move forward, maybe buildings may not be the thing we build more, but we build information infrastructure might be the future building of university systems, because I think that's where we should sort of be. I mean, we have information, how do we make that information available in the state, but also the world, ultimately. So, okay, that completes the talk now, right? It's the last slide, yeah. Anybody want to ask me any questions about what I just said? I mean, it's okay to interrupt me for questions, and I'm used to taking questions from the network as well. Okay, 2 questions. What are the questions?
Well, if you were, someone who in a state, they do not have any telehealth resources where they're at, but the aspect of it really interests them, how would you suggest them to start or to begin in that process?
Yeah, well, they could come visit us if they want to, and we could talk to them. They could participate in some of the video conferences that we're doing, and you can go to Kinko or there are video conferencing services, and most universities have them as well. And you can participate in some of the stuff that we're doing and learn about it, and we can talk to you about it. And then it varies from place to place as to where you go from there. I think it's always good to work with universities because they tend to be involved in some of this technology, and they tend to have fiber connections at the very least and expertise. And then I think, at some point in time you've got to engage hospitals and healthcare insurers because they have the money, and so you have to come up with some way of establishing the connections. There are hospitals that are getting involved in this stuff from the point of view that if they need for instance, if they need a neurologist, then they can contract with a national company that would provide a neurologist to your hospital on call. Now, I suspect this costs a lot of money, but it does provide access to a neurologist. And we'd be happy to work with anybody as well. I mean, to go across state boundaries for like telestroke would be somewhat of an imposition, but it could be something we could work out. So if anybody's interested in collaborating with us, we'd certainly be willing to talk to them. And we can help them kind of get started. And you got to come up with a way of paying for the equipment. I mean, we were fortunate that we had a Medicaid office that supported us early on in getting started. But you got to have somebody that really, believes in what you're trying to do with the whole thing. But we went from 0 to this thing in like 7 years, which is pretty fast.
Well, I was just going to say, Angels began with a sort of a patient focus as well as a provider focus, and I know a lot of our patients have benefited from, the decrease in travel and things.
Yeah.
But you mentioned billing, and do you see the climate for that changing in the next year or two related to billing and healthcare providers?
Well, I think that you can already bill for it in most states. Now, I mean, most states will accept telemedicine as, for billing. I think as we begin to go towards accountable care organizations are going to begin to rely on these sort of services to a greater degree, because using subspecialty support where appropriate saves money. So if you have a sick patient, if you get the appropriate consult from the individual, then they tend to order less tests and make diagnoses more rapidly and intervene more efficiently than if you don't use subspecialists. So the concept of using the network to make knowledge available across greater distances is a solid concept and is cost effective ultimately, particularly as the cost of bandwidth and network connections diminishes. I mean, the cloud stuff that the telecom companies are doing, a lot of that stuff makes the cost of information systems much lower. And as a general rule, bandwidth is dropping every year. So I think the likelihood of this stuff being more available on a cheaper basis, the cost of the network is no longer prohibitive in this thing. Early on in the old days, the network costs were just prohibitive. Now, that's not really the cost. The cost more now is the providers. But as we begin to realize that paying for the providers to make them more readily available, I'm more efficient if I'm a maternal fetal medicine person and only about 7% of pregnant women have high-risk OB complications, then if I could spend all my time taking care of the 7% with problems and not, part of my time with the sick ones and part of my time with the routine ones, then I'm more efficient because I'm trying to take care of sick pregnant women and fetuses.
That goes right into Mary's question from our live stream. What was the most exciting experience you've had related to telemedicine in your career?
I guess really kind of, there have been a couple times where we dealt with problems very rapidly that I remember once we had a patient that had it's called a molar pregnancy, and it's a kind of sort of a tumor inside the uterus that happens where the fetus doesn't ever develop, but can kill the patient. And so we did an ultrasound. The doctor called me. We set up an ultrasound on the fly that day, just within a matter of minutes. We diagnosed the tumor, confirmed it, and the patient got a D&C, got the tissue removed within a matter of a couple of hours. And normally, traditionally, that patient would have been referred to our system. It may take a couple of weeks to get the appointment, and then we referred them back, and then maybe another week or two they got to. So we've taken maybe 3 weeks to a month to probably intervene in this patient. And so that's an example of that kind of stuff where you do things really rapidly. Also, when patients have a question of the diagnosis and you can confirm it really fast over interactive video, then that's very important because the patients may have anxiety over 2 or 3 weeks while they're waiting to get the final diagnosis of their fetus. And then I've seen treatment of stroke patients of which they were not me personally doing it, but I've seen patients that had really serious problems in the ERs, and they got treated with TPA and they had resolution of their symptoms, and many of those patients would have gone on to be in nursing homes and had brain damage, but had an intervention that really made a real big difference. So it's those sort of things, I think, that where the tool is used in its full potential to speed up the diagnosis and management of the patient, that's most exciting in this modality. Trauma will be filled with these kind of success stories. Yeah.
Well, Michael had the question on how you see telemedicine playing a role in healthcare reform. Yeah.
Well, certainly, we create these guidelines, but there are always questionable sort of management issues with patients, and so the network could be available to do consults with doctors and patients in the field. There can be meetings with healthcare providers and hospitals to provide, the guidance and how we would reform this. Just sort of communications. A big part of healthcare reform is going to be how we implement these protocols to help change things, and getting a bunch of doctors and healthcare administrators, hospital administrators together is ridiculous. You just can't do it. I mean, it's not practical if they have to travel. But if you can do it over interactive video, then you can schedule these meetings once a week, as frequently as you need to have these discussions and bring everybody up on the same page of how you, really move this stuff forward. So I think that's kind of how you use it is sort of, again, to make the systems more connected as opposed to disparate systems. Now they're communicating and with interfaces and beginning to manage. It's a systems approach to management as opposed to a more independent, siloed nature.
Oh, we just had a comment from someone at the Oklahoma Health Sciences Center, just asking if we were going to have this talk available up on the website. And yes, we are. We'll try to get it up there tomorrow or early next week.
And we'd be happy to send the slides out.
Yeah, right. And we'll share you the slides too.
In addition, there was another question asking about our toll-free number to the South Central Telehealth Resource Center, and our toll-free number is 855-664-3450.
Okay, I've got another question online here. Any thoughts on how telemedicine would change the nursing role in healthcare across all degree levels?
You mean how should nursing training be embedded to do telemedicine?
They just say how telehealth, telemedicine would change the nursing role in healthcare. So maybe.
Well,
they do
I
more
think we
than-
already use nurses a lot in some of the healthcare delivery. Our nurses sort of manage the telemedicine patients just like they would in the clinics. They schedule stuff. They do follow up with the patients, and I think you're going to see that. And also, I think the use of APNs and other nurses in the more peripheral of the system, rural areas, underserved areas, it becomes much more practical from the point of view to be supported by expert systems, at a central site. So the nurses could be doing healthcare largely when they have problems or issues. Then there could be a level tier 1 that they consult, and that could be general OBGYN guys or family practitioners regionally. And then those guys then would consult with experts up sort of the system. And so you design an organized approach to healthcare delivery so that you diagnose things and upstream things more rapidly, and you treat things in situ in the local area much more effectively rather than bringing them upstream to a tertiary care center and not having anything done because it wasn't necessary. So I think by having expert systems kind of managing the network using this more effectively, and I'll say management is a two-way street. It's a collaboration between all members of the system to make decisions and do things, not a top-down really approach, but there should be involvement at all levels of the system with what goes on with the and when I mean that, writing the guidelines, following the guidelines, updating the guidelines, and consults when necessary to manage the patient so that we very rapidly. I'll tell you a secret. One of the big problems sometimes in tertiary care centers is patients will get referred to us, but they'll get referred to the wrong doctor, which means they got sent all the way to the university, and they should have seen a neurologist, and instead they got seen by a nephrologist. So that's a waste of everybody. And so it's better if you had a system capable of being sure that the patient got seen by the right specialists in that. And so I think these networks can certainly do that kind of stuff. How do they get to the right place? How do they schedule with the right person? See, so there's a lot of things like that you can do with a system like this. We have a 24-hour call center, which is very much a vital part of what we do in the management of patients, so that the patients call the 24-hour call center, the doctors call the 24-hour call center, and they can have patients referred in, have ultrasound scheduled, appointments scheduled all through the call center, even at 12 midnight. So that's made a huge difference in the way that our system works and interfaces with other providers.
Okay, I've got another one here on the chat online. Can you talk about the telemedicine education efforts and how they are different or similar to the distance learning that now exists in the colleges and universities?
Well, I don't think it's tremendously different, other than this stuff is more interactive. I mean, we have much more. It's not so much streaming as it is a two-way interaction. That's because we have the bandwidth and the equipment locally. But so I guess that's dramatically different. It's more like being in a classroom with teachers because you have built-in interaction. And I guess you could do that online too with texting, but it's a little bit less intimate, I suppose. The teacher in this could actually look at the students and see them with just streaming video. You can't really do that right now in most systems. I suppose there are some systems that you can do that, but this is a more. You could look, like if we had this set up right, I could look and see I could go visit the sites and I could look and talk to the people in the sites and I could see them and they could see me.
And echoing Dr. Lowery's thoughts there, we build relationships with the providers that come in to our educational conferences. So when they join on, they say, "Hey, Kurt," and Dr. Lowery knows them by first name. And the same way with the nursing teleconferences, we get to know the nurses out in those rural hospitals really well.
Mm-hmm. Right. So it's mostly about relationships. I mean, the whole thing in many ways allows you to build relationships, whether it's intimate relationships or relationships in new ways through streaming video those aren't as robust as the personal relationships we build through interactions, but there are still relationships that didn't exist prior to the technology. So I think the idea is to build meaning, trusting relationships. Ultimately, that's what you want to do.
I don't have any more online. I don't don't know if there's any questions we have from any of the distant sites that are on the interactive video. Oh, one that wants or just, wondering about an update on the Arkansas statewide trauma network. I don't know if that's something you can.
You mean what's going on with it?
Yeah.
Well, I don't know that much. I know they're meeting still. They're moving forward with it, and I know that we're going to be a part of it. But I don't know anything beyond that, really.
Does any of the other CDH folks out there have a different answer?
Silence.
Okay, well, I guess that competes this. Unless there's the
Here we go.
African American guy in the red shirt's got another question.
Yeah, someone was just wanting to know, maybe the latest on the Arkansas State Trauma Network.
So the trauma image repository is the trauma network part that we're ready to launch, and we finally finalized the contracts, and Terry Imus will be working with Children's Hospital and UAMS to get all those individuals and physicians logged on, and then she'll be working with the first 27 safe sites to get their images going to the repository. As far as the trauma network for telemedicine live consults, we'll have to write a proposal to the Department of Health for that. We're not there yet.
Okay, yeah, thanks.
We will be, however. And it's inevitable, right, that you'd be, the stroke stuff works very well, so. I can tell you that the new, we're hiring an intensivist, and he wants to do consults to the ERs for like MIs and other things that might end up in the ICU. So that's one of their concepts, is could they consult directly with our ER, but also maybe other ERs as well that feed into the system, with the idea of you start therapy sooner, kind of. So that's the way the trauma stuff would work, the same way. Who sent that in anyway, the trauma? Is it locally, or we don't know?
Yeah, it was probably locally. It said visitor. They didn't get a name.
Oh, okay.
So it was anonymous.
Okay. Anything else?
No more online.
Okay.
Okay, well, thank you
Thanks.
all for joining us today for our first webinar. Our next one is going to be July 17th at 3 p.m. Central Standard Time, and we'll have an exciting hot topic for us to discuss at that time.
Thanks.
Thank you.
Thanks, Sarah. Thank you.